Um, so we have the Martin Luther King celebration is next week. Please do register for that. I'll try to put the link in the chat at some point during the meeting. On the coming up later in January, on the 23rd, there'll be the update from the Johns Hopkins HIV cohort with Dr. Moore, Dr. Foho, and Dr. Wang. So looking forward to that. We have oncology updates. I left off the key feature here, which is that it's Dr. Rich Ambinder coming to give those in February. So please join us for that. And then we have two exciting in-person case conferences coming up. First on March 6th, arranged by Dick Chason, Dr. Kevin DeCoke, who's the former director of the CDC in Kenya, is coming to talk about his book, which is called Deployed, A Physician on the Front Lines of Global Health. And then on the 20th of March, we have our very own Tom Quinn, who's going to give us a HIV global update. And for those conferences, we will have in person with pizza and then over in Rango's, but also a Zoom option. So please do attend whichever way works for you. We'll be sending out an RSVP as we get a little closer so we can have the right amount of food. So now I will pause and turn it over to Sheila for the beginning part, which will be our Bartlett updates.
Great. Thank you so much for having me this afternoon. Happy Friday, everybody. Happy New Year. Sharing my screen right now. I am now. Everybody can see my screen. Yeah.
Yep, looks great.
Very good. Thank you so much. So it's going to actually be me and Dee, who is the Maryland PCP CMA. Why is this not working? Come on. Slideshow. Go. There we go. So, clinical operation updates, a lot of safety and patient experience benchmarks, core quality performance, metric, review, and then best practices for continued success and future initiatives. So just quickly, I always like to keep you guys updated. There are two new CMAs in the clinic, Tiffany and Gabrielle, and then Tiara Grimes will start on 1/20/26. Lakeisha, Kamala, Lindsay, and Deshara can all do fiber scans. Kenya is learning, she's almost done. And then all the CMAs will be rotating through the zone. So you might have different CMAs when you're here in clinic. I know you guys don't always get the same room, so you might see different CMAs. Just always a friendly reminder to use the Bartlett CMA group in secure chat for assistance if you don't see a CMA visible at the workstation, and then to communicate when you're running behind or if you have the ability to see patients earlier than your scheduled time. And then just check in with the CMAs at the beginning of each session to communicate anticipated patient needs or clinic needs. And then when you're not here, please just check Epic daily for messages and be in clinic during session times. And that's all. Does anybody else have anything they want to add to that? Okay. I don't know why things are not forwarding as I want them to. Hello? It's kind of frozen on me. Okay, yeah, it's just doing it, taking 3 times for me hitting enter for it to happen. So then, I want to hear from you all if you have any suggestions for clinic operations, any ideas. If you have any today, I'm glad to hear them. My door is always open. I'm glad to listen to any ideas that you have to make the clinic run smoother. So just thought I'd give a few minutes for that. And if you're shy, you can always come see me.
Or you can chat it to me and I'll say it out loud.
Yeah. And not seeing anything, so I guess I'm moving on. So next we're going to go to the quality measures. So this is from November. This is the executive summary for our HCAP scores, which is how people feel about their visit when they come here to the Bartlett specialty practice. And you can see that we are doing a great job in many of the areas. We're greater than 90%. So in staff quality and provider communication quality, hand hygiene, patient ID. We are in the 50 to 75th percentile in overall provider rating, and recommending this provider office, overall visit rating. And then the only two areas that we need to get a little bit better in is visit wait time and that staff worked well together. So, I sometimes think, I don't know, maybe patients see us talking about things and maybe they just think that it's not a well-oiled machine. So I'm not quite sure how to manage that, but we could make some improvement there. We're still in the 81% and 77%. So just
Sheila, are there any comments like on that response there? I'm interested as to what that,
what the staff worked
yeah,
well together.
yeah.
I have to dig in a little bit deeper on that, and I can do that. But I mean, overall, these are amazing scores. So thank you. Just kudos to everyone. And then I'm going to go on to our quality, safety, and service dashboard. And again, like lots of green, lots of blue, just a little bit of red here. So, OB chaperone discussed 100% of the time, non-OBGYN chaperone policy discussed 87% of the time, so almost at target. Exceeding target in closing encounters in 7 days in hand hygiene. On our heroes, which are our safety events that are entered, that there's follow-up on all of them. On our in-basket messages, they are read in 2 days. We're exceeding there. Interpreter services documented very close in that. And I'm going to talk about that a little bit at the end. We were at 76%. I put tips and tricks in all the rooms to make sure that we are getting interpreters and documenting the use of them. Medication review, some more work to be done there. When you see patients, make sure you're going over their meds with them, and then we're exceeding in patient ID. So great work again. On our primary care metrics, just so very close. Breast cancer screening, we're within 5% of meeting that metric. We're at 78%. Colorectal cancer screening, same thing. Look, we're like a percentage away from that, less than a percentage away from meeting that metric at 75.28%. Hypertension control, again, literally less than a percentage point away in meeting that metric. Hemoglobin A1C, we're meeting. Annual wellness visits, about 9% off the mark for annual wellness visits. I'm going to let Dee speak to that in a minute. Meeting the depression screening, kidney health evaluation, meeting that, exceeding that, and the statin therapy and diabetic patients without cardiovascular disease. Dee, would this be a good time for you to talk about the annual wellness visits and what December looked like and what we can do with the start of a new year? It is our metric of the month for this month.
Sure. The only thing I have for annual wellness um is we out of 81 visits last month that were scheduled, we completed 39. They were coded correctly, the questions were done, and only um four were not addressed and they were rescheduled. So the question would be um what needs to be done to help get these completed? Because we're still at 70. We've been in the red with annual wellness since I've got into the position since June of last year.
Is there anything else that D could be doing or the MAs could be doing to help to get these done? We put them in the schedule as annual wellness visits. We understand if a patient gets in front of you and there's too much other things to deal with, that just make sure that the next visit can be an annual wellness visit. I think when providers ask for them to be an hour long, we're doing that. Are there other things that we could be doing to help to get over the hump here, is what Dee and I are asking.
I'll just say personally that usually if it doesn't get done, it's because it ended up being a complex visit for some other reason. And I recognize that like just adding it on doesn't seem that hard, but if I didn't really go through it, then I don't want to do it, put the note in. But I don't have any other specific barriers. We've gotten so much better.
Yeah, we're almost there. Well, guess what? It's a new year, and we have a 12 months to get over that hump. So, that I'm always gonna be positive that this is gonna be the year. The same thing with the hypertension, colorectal, and breast cancer screening. I mean, just so very, very close. So any ideas that you have, anything that D and I and the nursing and CMAs could do to help to get over the hump? We're glad to help, so let us know. Any other comments? I'm gonna move on.
I'll just say I think it is really helpful when they're checked in and the MAs start the annual wellness because then you see the express lane in the visit. Um, so I think that's really helpful. I don't know if other people don't look there, if there's another way to flag it for them, but I think the express lane helps me.
Great. Thank you for that.
Yes. So it's from 8 to 11.
Okay. So then I'm going to go into our value primary care only metrics. So this we are meeting the metric that hospital discharges are contacted within 2 days and ED discharges are contacted within 7 days. Still some work to do about hospital follow-ups in 7 days or 14 days. And then still work to do on utilization. Hospital admits per 1,000 patients are at 121, trying to get to 67, and ED visits per 1,000 patients, 296, trying to get to 151, and our readmission rate, not too bad, 12.94%, and we wanted to get it to 11.3%. So I know that Fatima did leave her position, but the nurse that I am hiring into Fatima's position will continue to work on this. And there is the plan for that nurse to really be looking at are folks who are higher utilizers of ER and hospital and to try to move the bar on the readmission rates and the high utilization of hospital and ERs. Any comments for this? So this is just another way of looking at that. Really nothing more to say about the utilization and quality program. The hemoglobin A1C, we're doing great. Depression screening. We did have a patient family advisory committee. We do meet with our local hospital. We know about our readmission rate and um our ER and hospitalization follow-up. And then just looking back at here we are with all the scores again, just seen in another way. So here's our chaperone one. So you can see we're meeting that metric, which is really good. We're at 90%, and this is as of January the 7th. So we're exceeding there. So great work, everybody, on that. And then this is our interpreter services. We're at the 73.59%. So we need to get a little bit better. I'm sure we're using the interpreter, but I want to make sure that we are documenting that we're using an interpreter. So this is what we put over the holidays while providers really weren't in clinic. In each of your rooms now, there is in the rooming tab a communication interpreter tab. You see on the number 2. And then on number 3, you put what services that you used, and you have to put in the interpreter's full name or ID number. You can also use the smart phrase of interp assist or QBS assist. And once you use that smart phrase, again, you will be able to write in which interpreter that you used. And this is the only way that we get credit. So these are laminated, they're in each of the rooms. So I just wanted to make sure that we are getting credit for when we're using an interpreter. So put that in the little wall folders with everything else. So if you forget how to do it. And then to know that you need to get an interpreter is the identify the preferred language in the storyboard and update the preferred language if needed. Okay. And then again, I showed you about the rooming tab. If it says that somebody language preferred is other than English, then that's when you have to get an interpreter. So continued best practices, RNs continue their outreach efforts. So if there are patients that you want to, that you're worried about, that they're lost to care, that need these mammograms, that need colonoscopies, that hypertension is not well managed, please let the nurses know that. Please continue to have team meetings to discuss complex patients and address these overdue care gaps. If you haven't established a care team meeting, consider doing that. Optimize your same-day workflows, such as mammograms and trying to get people over for diabetic retinopathy screenings and JHOC. We really don't do that, and we should try to do it. D continues to try to make rounds with providers and to check in with providers about the same-day mammograms and diabetic retinopathy screening. So she'll continue to try to remind about that. So just ensure that your hypertensive patients have follow-up appointments within 6 weeks. If they do have a blood pressure that's greater or equal to 140/90, have them rest and try to do the Omron, so maybe the blood pressure will come down. And then they can have follow-up appointments with the RN or with the PharmD for medication management. And then with the annual wellness visits, again, we've been asked to schedule them. We're doing that for a year out. If it wasn't done, please indicate, in your next note that it can get done. We do have a Mina here now who can meet with patients post-hospitalization, or if you're concerned about how they're taking their medications, that's the transition to care improvement. And then Jen is the nurse that is following up with patients who need assistance with getting colonoscopies or Cologuards done. And we do have 2 demo kits here in the clinic if you want to show them to patients while they're in here. And then the NEPO has moved along in Bartlett, and that is now hopefully in the next month or so it's at the medical board, and I will let you know when it's published. But there will be a NEPO for folks to have orders placed for UAs, micro and CNS, also for Nurses will be able to do that. And then for our folks who are getting initial or re-engaging in HCV treatment and HIV treatment, to get their initial lab work done. So instead of a provider having to write the orders, the nurse will be able to do it via NEPO. And then D will continue to sign the well visit questionnaires to patients using my chart. D is outreaching people for Cologuard, and then continued work around intensive follow-up for high risk, high utilizers. So those are still, some of that's already implemented. It's actually not a future initiative, it's a present initiative. And that's all that I have this morning. Does anybody have anything for me or D? Thank you all.
Well, thank you both Sheila and Deshira for all of the work you do for our patients and for making the clinic function for us and with us. And we're going to make it. It's 2026. We're going to get all those metrics.
Oh, and D, I think there was one other thing that D wanted to talk about. Like, if you're the care team cleanup, make sure that you're noted on the care team as the primary care provider. So, when you're seeing patients, just kind of a mental reminder to like make sure you're a part of the care team if you are the primary care doctor. Right, D, you wanted that to be brought up?
Yeah, just some of the providers are listed as PCP with other or outside providers. So if your name is attached to the patient as a PCP, that means we need to complete their those care gaps. But if you're not the PCP, um you can still be a part of the care team. It's just your name can't be under the PCP section of it.
Got it. So that'll help us with our metrics.
Yeah.
Yeah.
When
So
we're like, oh, they have someone else taking care of this, it'll
yeah.
also show that in the system.
Yes. That
So
way
we're not attributed, yes.
Right.
and that's what takes that away, because if we're attributed to them, that means it counts towards us when it's not completed, and that will help out a lot.
With our metrics.
Yeah.
Yeah. Okay, great. Well, thank you so much. And as Sheila said, they're open to suggestions and feedback, and we'll continue to work as teams to care for our patients. So great. So now we're going to shift gears a little bit and head into our